When Joel moved on from being the commissioner in the state of Pennsylvania, he ultimately ended up working for the U.S. Department of Health and Human Services, heading up the exchange office, or what, I forget exactly what it's called, but anyway, Joel was the guy at the top of these exchanges and all of that sort of thing. And Joel, by the way, is a lawyer. He's a graduate of Harvard Law School. I tell you this by way of informing you that Joel is the perfect person for this morning's presentation. He's got a deep background on health and health law, and without further ado, let me bring you up, Joel, please.
Figure out where to put my water here, because I'm going to put it right up here. I hope that's not distracting to anybody. Thank you for that kind introduction, Roger. Roger was also an officer in the NEIC. He and I became friends early on when he came into the NEIC, and I remember the year he was president. He said, I know you love healthcare and I want you to stay doing healthcare, but I've also got this other assignment that I think is going to be pretty good for you, global warming. He said, President Obama is going to make that his top issue. It'll be an easy issue here at the NEIC, and you can really be a hero for us on this issue. So of course it started out that year pretty good. We got a unanimous vote to do this global warming questionnaire for all the insurers, and we were going to show that most insurers did really follow the science and had a concern about global warming, and so that all passed, and it all looked like Roger's prognostication on that was going to come true. Of course, somewhere in the middle of that year, the president said, well, global warming is a little too controversial for Congress right now. I'm going to do this easier issue called healthcare reform instead, and he kind of put global warming aside. And by the time the year ended, when we had all done all the work to kind of put this questionnaire together, and it had all the technical pieces in order, came back to the plenary and said, here it is, let's move forward. And the same group that had unanimously approved this early in the year said, we're kind of with the president. This issue is too controversial. Let's put that questionnaire back in the box. And I don't know if it ever did come out. I know there are still global warming meetings at the NEIC, but I'm not sure that it really has seen the light of day in the way that we originally envisioned. And then I, of course, went back to healthcare, which is my real passion, and worked for the administration, and now am in private practice, and it's one drama after another with the Affordable Care Act. Roger said, I am an attorney. I will confess to that, but I am not a practicing attorney. I did do the project up here on legal work, but I had a couple attorneys with me, and I've always looked at these things more from a policy perspective than from a legal perspective, especially this early in the morning. I don't intend to inflict a lot of arcane legal doctrine on anybody in the room, but I thought maybe a good way to approach the three legal issues that kind of come to the fore when you talk about payment reform is that I tell a story about each one, kind of illustrate how it fits into a policy framework for an insurance commissioner, and then I think for the other stakeholders that are around payment reform. So the three issues that I'm going to talk about are risk-bearing. I mean, whenever you talk about who's going to be a risk-bearing entity, the insurance regulator ears perk up, and they want to be concerned about solvency particularly, but other issues around consumer protection as well. So that's issue number one. Who's bearing risk in the system, and what does that entail in terms of, particularly in terms of insurance regulation? Issue number two is the system of fraud and abuse. The system is kind of built around the notion that we have a fee-for-service orientation, and so the real danger is over-utilization of services, and so we need fraud and abuse statutes to protect the public against against gouging and self-interested dealing and all of that. That obviously changes a little bit if the payment is maybe reversed, and now maybe the danger is underutilization. The incentives are to use fewer services, not more, from the provider perspective. And then issue number three is antitrust. We're a country that basically believes in competition, and more is better, and so not letting people consolidate too much is kind of in our bone marrow. And so now we talk about ACOs and other forms of vertical and horizontal integration that maybe want to make us look a little bit differently at antitrust. So each of those issues I'll talk about for a few minutes, and then leave plenty of time for questions. So first issue, I always go back to my very first experience as an insurance regulator. In 1995, I came to work for the Oregon Insurance Department at that time, and my mission was, from the commissioner at that time, was to put together a small group reform law for the state. But as we were doing that, there came this issue of, some of the insurance companies were complaining to us that some of the big self-insured employers were going to cut them out of the loop and contract directly with provider groups. And what were we going to do about that? Because that would essentially mean that that these self-insured groups were putting risk down on providers without an insurance company in the loop, and that really should make them be insurance companies. So my boss, Kerry Barnett, who Roger knows was the insurance commissioner at that time, said we need to write a bulletin on this issue. So we dashed off a 2-page bulletin, and it ended up being 1996 by the time the bulletin came out. And it basically said, if you as a self-insured employer intend to pass risk down to providers, you need to come to us and get an insurance license to do that, because you become a risk bearing. You're putting risk on these guys. You're ultimately holding responsibility. We need to make sure you have the capitalization, all that, of an insurance company. We did create some safe harbors. If you're doing fee-for-service business, you can be. That's okay. That's not passing risk on. And then we kind of got into the intermediate stuff of all certain kinds of withholds, fee-for-service. Some of this will be familiar to people who've been around the world. This was the nature of risk bearing back in the late 90s, fee-for-service to withholding, tiny little steps forward. That would all be okay. But if you're going to this thing called capitation, where you're just, sending them all the money and they have to bear all the risk, then that really does take an insurance license. So that's the bulletin we wrote, and it kind of, that whole way, pushing capitation kind of became, backlash from the consumers, patient protection laws and so forth, kind of went away, and we were back to PPOs for about a decade here before we came to this next round of payment reform. And so about 2013, I guess it would have been, just after I'd come to Manatt Health Solutions, I got a call from a provider group in Oregon that said they wanted to talk to me about their ability to take on risk from large employers. And I said, well, why are you calling me? And they said, well, there's a bulletin we understand you had something to do with that's kind of a barrier to us now in doing this, because it says we can't work with these self-insured employers. We can't bid. Only the insurance companies can bid on this business because they don't want fee-for-service type bids. They want pretty aggressive risk sharing and risk bearing by the provider group. And so I took a look at the bulletin and I said, this reads like it was written by a couple people who were just starting out in insurance regulation and didn't know the way around the circus. So we worked on that issue then in Oregon for about a year, trying to find an intermediate point where the insurance regulatory system could support some forms of risk bearing, and we eventually ended up with a meeting with then Governor Kitzhaber, his chief policy aide, talking about how we needed to do something to make it easier for providers, and kind of presented the case. And we said it's kind of odd that the state is really experimenting and pushing hard on the Medicaid side and trying to get that into the insurance side as well, that we want to end fee-for-service and have broad payment reform and outcomes-based kind of payment systems and so forth. And now on the insurance side, we have a rule that says if you, as a provider entity, an organized one of these consolidated provider entities, wants to contract with a self-insured employer, a large self-insured employer, progressive-looking one that wants to do payment reform, the one thing that you can do is fee-for-service. That's the one thing that we're encouraging you to do, because that's not a safe harbor. But anything else along the continuum towards risk-bearing is kind of risky for you from a regulatory perspective. And he started listening to us, and then he said, I get it. We need to do something about this problem. We need to figure out how to make it easier for provider groups to bear risk in these situations, and how to have a more fulsome market and so forth. So that, I thought, great, we won the war here. Well, that was about 1.5 years ago, and they're still trying to find the intermediate ground in Oregon. Point being, this is a tough issue, because it does, I saw Mike's eyes rolling as I was finishing that story, because from the insurance regulator's perspective, if the if there's an arrangement here where there's a lot of risk being put on the provider group and there's not an insurer in the loop, that's a difficult situation for consumer protection, because you really ask the question, who's holding the bag in that kind of deal if their claims become more than you think they were going to be and there's a financial problem, who's really holding responsibility? And you kind of, as an insurance regulator, like there to be the answer to be one of two things: an insurance company that's well capitalized and regulated, or the government. Now, government's okay too. So if you looked at our paper now, tying this, now I'm going to get down a little bit out of the clouds into the stuff that's in the paper. If you look at the paper, we basically say in there that this kind of risk bearing is absolutely fine by provider groups where there's an insurer at the top of the food chain, because then ultimately the insurer is bearing the risk. The provider group can bear a lot of risk underneath that, but if the provider group doesn't work out so well for the provider group, you still have this insurer to answer to the consumer, and you don't have what Roger and I both know to be the worst situation, which is an insolvency where somebody's got to pick the pieces up and figure out what to do. The second situation where this is all okay is if you have the government ultimately bearing the risk, and that would be Medicare or Medicaid. So each of those entities can contract directly with provider groups if they want to bear risk, and ultimately, if it doesn't work out for the provider group, the state, in the Medicaid side and the federal government, the Medicare side, is holding the bag. Now, it turns out most of the time, Medicare and Medicaid, maybe almost all the time, they actually like these insurance principles too, so they basically contract with insurance companies, not directly with provider groups. There was an experiment in 1997, the precursor of Medicare Advantage. The federal government was worried that insurance regulators wouldn't license new entities to do, again, a Medicare Advantage style program. It was called something Medicare Choice, I think, at that point. So they created a cut-through in federal law that said, if insurance regulators don't license these new entities to do Medicare Advantage, I'm going to call it that because that's what it is today, then we, the federal government, will have our own way of licensing. And we all got together at the NAIC and said that would be horrible, and created some streamlined ways for us to do the licensing. And that part of the Medicare law never went into effect, and Medicare Advantage is now done by licensed insurance companies licensed at the state level. And here in your state, Medicaid too, the Medicaid MCOs, you brought the insurance companies into that world, but they're brought in as licensed insurers. It wouldn't have to be that way, but it is that way today in Medicaid. So by and large, you have that kind of system. But then we're still left with this problem. What about the self-insured employer that doesn't have an insurer up the chain, isn't the government? How do they play in payment reform, and can they contract directly with these provider entities that are taking risk from the government, taking risk from insurance companies? And that's the challenge, and I think that's probably fundamentally why you had this part of this project was, are there ways to deal with that situation? They're very tough. I mean, going back to the Oregon story, they still haven't figured out how you square the issue of you want to make sure that somebody is accountable to the consumer if things go badly, but you also want to encourage payment reform. So we've got a couple ideas in the report, and they're kind of a little bit, I think, may come up in the discussion of the recommendations. The ideas are, one, and this has been experimented with a little bit in different places, you can try to talk about intermediate sorts of risk. So provider groups they're not taking the full risk of an insurance company. They might be taking a more limited risk, and then the amount of financial heft or capitalization they have to have might be less. So Colorado has a program for behavioral health where an entity can take on behavioral health risk without having the full capitalization required of an insurance company. And this is a familiar concept to insurance regulators, risk-based capital. Long ago it was decided that we don't want every insurance company to have exactly the same levels of capitalization. We want that to be calibrated to how many customers they have, how risky the business is, how risky their investments are, et cetera, et cetera. So that concept of risk-based capital and the amount of capitalization you have to do different things should be based on the amount of risk. So there may be potential in that kind of answer. Massachusetts has that sort of answer in their global budgeting system where, under a global budget, big hospital, they're taking a lot of risk under a global budget each year. So they have this concept of risk certificates that those entities have to have risk certificates, and they show that they're properly capitalized to meet the risk. The second thing, though, and this kind of gets into the parts 2 and 3 of the presentation, is now in those situations, those provider entities are behaving more like insurance companies, and so the risk is already shifted there too, from the risk being overutilization because I'm getting paid by volume to underutilization because I'm being paid a flat fee or something approximating a flat fee. So you also start to think, well, maybe these entities ought to have some of the kind of regulation we have of insurance companies about, a right to complain, appeal, and challenge things, and maybe some utilization review standards to make sure that there's not, we haven't incented too much underutilization, all those consumer protection issues that insurance companies face, providers taking on risk end up probably facing as well. And then you can get into some more calibrated things, and now I'm getting as far into the weeds as I'm going to get on this issue, but you can say, gee, if I'm an insurer here and I've got a provider group here that's taking risk through that insurance structure, and now I've got another situation where the customer is a self-insured employer, so they're not paying me as an insurer, they're paying me as a TPA, and all the big insurance companies are TPAs too. And we want that same provider group in the network. Well, that looks pretty much like the same deal, so we'll let that provider group bear risk in that sort of situation, even though technically the insurer is not behaving as an insurer, they're regulated as an insurer, they're regulated as a TPA. And then there are things you could do with all the TPAs. This is one of Tyler's big interests, is what can we do to regulate TPAs and help, particularly I think around issues like disclosing data and that sort of thing. TPAs can be very helpful because in all these deals there is somebody helping the large employer manage the whole thing, and usually that's in the category of a TPA. So that's issue number 1, kind of broad picture on how to address risk bearing. If you guys figure out what's the ideal way to calibrate in the middle there somewhere, that would be wonderful, because other states will be eagerly looking at it, because most of our research on this did consist of calling and chasing down leads on, okay, we read somewhere that in Minnesota you were doing X and Y to have a middle level solution for some entity that wanted to work with the providers. In almost every case, well, we tried that, and either nobody wanted to do it, or we couldn't make it work, and so most of those things went by the wayside. That Colorado one I cited is one of the few that actually stayed in the marketplace. So the other 2 issues are a little quicker, and then we'll get to the questions. Fraud and abuse. There are federal anti-kickback statutes that basically say you can't do self-interested dealing, that may feather your own nest if you're being paid on volume. You can't do self-referrals in most contexts under federal law, Medicare and Medicaid. And then there are state variants of this. The state variant of the referral law here is just a disclosure law, so it's probably a good thing to keep in any of these events. We're moving towards a much more transparent world, so that's definitely good all the way across. It doesn't really prohibit anything, but you have that kickback statute that does apply to Medicaid, that doesn't apply to commercial market. So you may want to look at that in the context of Medicaid, particularly now that you're having Medicaid moving to the commercial market and the alternative expansion and so forth. But here's my introduction to that set of issues to show 2 stories. One, to show you that there's clearly does need to be some reference, some attention to this issue. One of my first trips as the exchange director at the federal level was out to Washington State, meeting with a bunch of provider side folks, mostly hospitals, and I literally got this question. So would it be okay for us to say we have a patient who is qualified for Medicaid now, we're really not going to get much of a reimbursement for them, they're going to be a very expensive case for us. If we hired them as an employee and paid them for a month as an employee, they would then meet the income threshold to qualify for exchange coverage, and then we would get a better reimbursement. Can we do that? My immediate gut was, well, that's, I don't know what the rules are exactly here, but no, I don't think that sounds right to me. You shouldn't be able to do something like that. So there clearly is a limit, and I was sort of shocked that they even asked that question, but it was in the early days and kind of like, well, the law's the law. We want to find out where the limits are. So, take a little sip of water here. I have it next to me, so I don't have to reach like a Rubio or whatever. But so then the next, my next experience of this was sometime after I'd left the agency. I was doing a presentation in one of the large drug companies with one of my colleagues, and the issue of, well, what about these drug programs where we help people with their co-pays and all of that? Are those going to be okay under the Affordable Care Act? And my immediate reaction was, yeah, I think so. And what I had in mind was, you know, I remembered the situation in Oregon where the auto glass people, anybody ever had their windshield fixed, and they say to you, well, not only, I'm not sure I should have it fixed, it's got a little nick. Well, no, you definitely should have it fixed. We'll take the whole thing out, replace it, we'll pay all of your co-pays for you, and not only that, we'll give you 6 pizzas on top of that if you'll let us repair your windshield, because then they, of course, go get a pretty good price from the insurer for that auto glass. And so I had people calling me in Oregon saying, this is consumer fraud, it's really, you know, totally ruining the moral part of the insurance contract. And so I said, well, I'm not going to necessarily get in the middle of that, but, you know, go try that in the legislature. And the guy was one of the best lobbyists in Oregon, and by the time he was halfway through his first hearing, he was really wishing he had never brought up the issue, because everybody in the legislature was. So you're saying that you want to pass a law that prohibits the auto glass people from giving consumers a better deal, an easier deal on getting their windshield fixed, because you think it violates some principle of insurance payments that we don't even understand what you're talking about, kind of thing. And so that was my frame of reference for the issue. But my partner immediately got up and said, Joel, I don't think you're right about this. I think the federal government is going to rule that the kickback statutes do apply to that situation, and so the drug companies or the hospitals cannot have those kind of programs under the ACA. And so we went back, and I said, well, Wendy, you know more about this than I do, so maybe you're right, but I'm telling you, if it gets to the state level, I think it's going to come out the way I said. We kind of went back and forth, and then about a year later, the federal government kind of went back and forth. It said a letter was sent from the secretary saying the kickback laws don't apply, and so hospitals and drug companies can keep their, you know, essentially rebate programs. And then the Inspector General said something that seemed to contradict what the secretary said. And so this issue, I mean, there are some of these entities that are more, you know, risk-taking, that are doing these programs pretty aggressively. There are still legal counsels to some of the big hospitals and drug companies who say, you know, be very careful about that whole area, stay away from it, because we never know when the federal government's going to come back and say these are kickbacks that are going to be illegal under the law. So that's the kind of milieu you operate in on these kickback laws. But clearly, I mean, as we say in the paper, if you're trying to set up a system, an ACO type of system, you do want to create some flexibility for people to refer within the system. That's the whole idea of a coordinated delivery network. So you clearly have to look at these laws and figure out how to address these issues in the best way possible. You don't want to just, and the federal government's done that. They tend to do it in, you know, single chops here and there, but they have said, you know, for the Medicare ACOs, these laws don't apply. They've just given a blanket exception from these laws. Stark law, the kickback law, the gain sharing law too. There's another law about, you know, giving incentives, hospitals giving incentives to withhold care and so forth. All of that we're going to put in abeyance for Medicare ACOs, and I think depending on what you guys want to do here, you know, you may want to look at that Medicaid law and figure out what makes the most sense with that law. So the final area, antitrust. And here my experience was in Pennsylvania, where I sort of why the governor wanted to steal me away from Oregon to come to Pennsylvania was because he had these two big insurance companies, Highmark and IBC, the two big blues in Pennsylvania, wanting to merge. They called it a consolidation, but, you know, essentially a merger. And he wants somebody with a healthcare experience to kind of look at that for the state. And so I got very involved in that for 2 years. And I still remember the first time I met the CEO, Ken Milani from Highmark, and he said to me, let me educate you on one thing very clearly here. We absolutely need this if you want any ability to control costs here in the state of Pennsylvania. Because we know what happens when the providers have the upper hand on us. And it's what happened in central PA when we couldn't get a consolidation with the blue in the central part of the state capital, Blue Cross, and we had to go into competition with them, the providers got immediately a 10% increase in price. So if you make us compete all over the place with the other blues, and the blues dominate in Pennsylvania, you will have higher prices everywhere because the providers will exploit, and they have exploited me, and Highmark does not get nearly the prices that we want in central PA that we can get in Pittsburgh, where we control more of the market. And he was explicit about all this. At one point I said, so I used to work for Ralph Nader, and I believe in competition now, and you sound like you're from Europe and believe in single payer. He goes, you have it exactly right. I told me that one day. So anyway, that was that view. Then, you know, it sounded, frankly, it made some sense, right? I mean, if you put these two big giants against each other in central PA, it does get rosier for the providers at some level. So I said, well, you know, my guys are going to need to think about all this. Then we hired our economists and all that sort of thing, and our economist, former guy from the FTC, in the end persuaded me he's absolutely wrong. Because yes, maybe there's a short-term gain here if you have that kind of consolidation, but it doesn't really work to the consumer's benefit because there's nothing to force them to pass those savings down to the consumer, and so this isn't the best thing. What you really want to do is have as broad a level of competition at the insurer level as you can, and you know, same thing at the provider level. You want to have as much competition as you can, and the difficult fact for Ken Milani and IBC, why I eventually ruled against. Actually, they withdrew it because we told them we were going to rule against it, but that merger didn't go through, was because actually when everybody testified, not just the providers, not just the hospitals, but all the consumer groups and all the other stakeholders, they said the market in central PA, where there's more competition, is more robust than the market in either Pittsburgh or Philadelphia at that time, where there's more concentrated power in the blue. And so the final deal I actually offered those guys was, you can have this merger as long as you, Highmark, give away one of your Blue Cross, you give away Blue Cross and keep Blue Shield, so that we can let Anthem or another Blue Cross plan come into the Philadelphia and compete with you in Philadelphia, just like you compete with Capital in central PA. And they said, we don't want that deal. Well, that's the only way you're going to get approval. So, point of that story, antitrust is important. I have it in my bones that it is. And so you do want to, you know, where you can, have as much competition as possible. And if you want competition at the carrier level, and kudos to Roger and the team here, I mean, you guys were poster child in year one of the exchanges for a single carrier, and then they excluded, what, about 15 major hospitals or something, or 15 hospitals, and you know, it was a big controversy. And then what, you have 5 in year 2? Yeah, so more competition at the insurer level, good thing. And in general, you know, I've cast a wary eye on consolidation at the provider level as well. Having said that, the whole point of an ACO is to consolidate up, and Peter, we're going to have the panel in a minute that's going to talk about, you know, how you're trying to pull 4 hospitals together in northern New Hampshire. So some amount of consolidation is right, and so I think you do have to revisit these issues too. Last 2 points, one that's new since the paper was written. Well, let me get to the first point first, which is, if you're going to try to relax this antitrust vigilance, then I think you do have to do something like the federal government did, at least change the rules a little bit, say certain kinds of deals are within the rule of reason and they're all going to be okay under state law. And then number 2 is, you might want to have active supervision at the state level of some of these kinds of arrangements to make sure that they serve good purpose. So that kind of approach, and it was in a bill here, Senate Bill 308, which didn't pass last year, right? But to create some kind of, and the two key things are clear articulation of the purpose. What is the purpose of having this exemption from antitrust? And then active supervision at the state level. It has to be that the state is not only articulating the reason for doing this, but they're actually on the ground monitoring for that purpose, so that it's not just willy-nilly any consolidation, it's ones that serve whatever is the clearly articulated purpose. So we articulate all of that in the report. Since that time, the Supreme Court has weighed in on this issue in a slightly different context. It didn't come up, I wouldn't say, in the most favorable way for people who wanted the federal government to leave states alone. It came up in the context of dentists in North Carolina who didn't like dental assistants doing teeth whitening. They said dentists needed to do teeth whitening, and so they sent out letters from their state dental board saying, you know, you must cease and desist from doing this unless you have a full dental license. So it's not the best fact for somebody who's trying to defend one of these state programs. But the other facts were that, you know, the board was all dentists, and there wasn't any real active supervision by the state. These guys just did what they thought was appropriate, which is like, well, we want to whiten teeth, not you. So that came to the Supreme Court, and they did articulate in a major case this year, Dental Examiners of North Carolina versus Burwell, that we mean, you know, the law does mean what it says. The standard does mean what it says. There has to be a clearly articulated purpose, and there has to be active supervision. This North Carolina deal doesn't pass muster, and so now basically states are a little bit more under the gun than they were if you read our report about what it might mean to have that kind of system in the state. You really do have to make sure you meet some higher bar, and we should look at that Supreme Court case. That a lot of people looking at that case have said probably what happens next is that states start to articulate model laws for what it means to have an active supervision level, and probably, that may have been already happening. This case only is a couple months, maybe even a month old or something. So that's the antitrust issue. So the last thing I'll say, then turn to questions, is that I think this has always been my view since I started in insurance regulation. Remember, I have this Ralph Nader type background, I'll confess to that, is that the best single thing to ask every time, if you want to make sure that you're kind of keeping yourself in the right orientation for how to solve all these difficult issues, is what does this do or not do for the average consumer? If you just ask the question, how will this play for the guy who's actually, or gal who's actually paying the bills, directly or indirectly, wants the services, is this just good for my interest, or is this, can I articulate a way in which this is actually good for the consumer? And if you stay on, you know, always asking the question, what's good for the consumer, I think you get to the best answers. And one of the reasons it was, I was saying to Roger this morning, my favorite job ever, and well, I'm pretty sure it will be because I'm getting pretty old now, insurance commissioner. I'll never get another job as good as that one, because the people who do that job end up, whether they're from the left or from the right, they end up coming to some kind of ground of, you know, it's too hard to figure out what the conservative answer is, what the liberal answer is. I'm just going to figure out what the consumer protection answer is, and if I stay there, I'm going to be better than anywhere else. So with that, I'll stop and open it to questions. And somebody's going to give me the hook whenever I'm supposed to stop, right?
Tyler.
All right.
I guess I'll start. I'm kind of a layperson in the room here, but I thought what I heard you just say was there's kind of three things to look at that's important in your job for years, everybody's jobs in insurance, to look at risk, solvency, fraud, abuse, no self-dealing, antitrust, and more is better, right? Kind of my boiling it down. And then you went on to say that the ACO type of thought process appears to violate number 2 and number 3. But if we put state regulators on the ground to monitor it, that somehow that's a good thing, that's an okay thing to do, it seems kind of counterintuitive to me.
Good question. That's a good summary of what I said. And so I do think, yes, and it's as a starting point, if you say, how does the ACO movement fit with traditional regulation, you come to the conclusion that there will be problems under fraud and abuse laws, there'll be problems under antitrust laws. What I didn't articulate, and I think the next panel will articulate more, is there is a strong rationale for having ACOs, coordinated care. We clearly do. I mean, I deeply, deeply believe in the consensus that's forming, and in this state it seems stronger than most states even, that you have to get away from fee-for-service. In business, you get what you pay for. And if you're paying for volume, you're going to get volume. So we have to get away from that system. We have to get to something that's more triple aim, outcome-oriented, capitation, or forms of bundled payments where providers are taking some risk and they're rewarded for managing in larger context than just every single episode. So I didn't get into all of that rationale, but there's a very powerful rationale for doing that. And what I was saying was that that rationale is coming down the tracks, but you need to be aware of these two issues. And yes, you probably should make some allowances and changes in your law so that your fraud and abuse principles and your antitrust principles don't end up forcing you back into, well, the only thing you can do is fee for service. Remember the story I started with was this, I mean, it really did shock me to think about, oh, geez, so that simple articulation of insurance principles, which is you can't do these kind of deals with self-insured employees unless you do it through fee for service, 15 years later is telling the provider groups that let's do only fee for service because everything else is risky under state law. That's not a good place to be. You need to figure out as a state how to get past that.
So then what you then said is that the next panel is going to answer your next question, which was that ask if it's good for the consumer, and that leads to the best answer.
Well, I think they're going to make some recommendations.
So they're going to explain why this is good for the consumer, such that we should put regulators on the ground and let kind of the industry kind of get around the self-dealing antitrust issue.
Well, now you're putting words in my mouth that I wouldn't put in my mouth.
You wouldn't put it quite that way.
But, I think this is an illustration why these are good forums to have, and there should be voices like yours in the room saying every time, okay, you guys have well convinced yourself that let's not worry about fraud and abuse, and let's have a broad antitrust exemption. Well, I'm coming from a consumer perspective. You need to convince me that that's actually good for me. They should have to answer your questions. I think that's absolutely right. I do believe they'll be able to, but it needs to be answered.
Okay, thank you.
Just a comment and then a question. The comment is that this concept of provider competition actually being a good thing and keeping prices down, I think the comment is that without transparency, that's an artificial concept. The question would be in, for example, northern New Hampshire, how do you introduce provider competition in a rural setting with limited providers?
So, first of all, I agree with your comment that yes, there are very few things where you can say almost every argument for doing this is good. There are no real limits on it. Transparency is in that category pretty much for me. If you think of a form of transparency that you want in the modern world in healthcare, it's probably a good thing to pursue, and we are pursuing it. The CMS is busy. Marilyn Tavener said data liberation was the most proud accomplishment in her tenure as a CMS administrator. They're opening up the vault of data. It's a good thing. There are some ways in which transparency sometimes can be used to keep prices down in certain kind of context. If every hospital wants to know what every other hospital is paying nurses, that might not be such a good thing. But almost all the time, transparency is a good thing. And then your second point, and it's very relevant to a state like this, is all this competition stuff sounds good, but what does it mean in more rural populations? And the answer is it's very difficult to make any kind of competition work in those environments. I've had to change the way I present around a lot of issues with the ACA because I tend to talk about competition being good in all these different dimensions, and bring, like for instance in the exchanges, I say don't have just the exchange portal be your place to sell insurance. Work with web brokers, the e-healths of the world, create more portals and open up the competition even among public and private exchanges. And invariably, when I make comments like that, I would get the people from the most rural states coming up and going, okay, well, so can you put me in touch with eHealth or get insured or somebody that will help me figure out how to execute on that? And I have to, then I go back and I kind of learn from painful experience and be like, well, if you're in a major city, this is all to the good. If you want Uber, you can get it in a major city. But when you say, I want that up in, I couldn't get a cab this morning here. I was 15 minutes late getting a cab. So, when you want these things in more rural areas, I don't have a good answer to you. I think that you have to have a different set of rules. I kind of like, Tyler, one of the things you sent me a while ago was we're looking at network adequacy differently in different parts of the state. I think, so that would also tell me federal government trying to do a one-size-fits-all set of network adequacy standards for the country, pretty scary to me. It ought to be state by state, and then within states. A wise commissioner would be saying it's going to be different in different parts of the state, and almost all these issues have an asterisk around, might have to be different. And Peter's going to answer all of that question in his part of the panel, right?
So, since you're the commissioner of Pennsylvania, I have spent a little time in Pennsylvania. You had put in, I don't know if that was you or the state before you were run, put in the Pennsylvania Healthcare Cost Containment Council.
Yes. That was there when I came, yeah.
So how successful has that been? Was that transparent?
Well, it's interesting. I would say not that successful. I don't know it in the last few years. I have really not spent a lot of time in Pennsylvania politics since I left the administration in 2010. But up until that point, it was very controversial in the legislature. Every year, sort of like the Medicaid expansion is here. Every year, it's like a fight to keep it moving forward. That's how that was as an issue. And part of it, to my mind, was that you know we were just touching the surface of transparency at that point. So even though they produced some pretty interesting reports about, they were cutting edge in terms of their reporting on different kind of hospital metrics. It was still primitive enough that it really wasn't getting the attention of the average consumer yet, and so they were, you know, transparency does gore some oxes, and so they were kind of always, they didn't have enough of a consumer constituency to follow what they were doing. My sense is up here, you guys have more, the way in which you've built your transparency does have more penetration in the market, is more solid than it was there.
So, one question, why do you think it wasn't adapted or taken? Why do you think it was not?
Because it wasn't enough transparency. I mean, my model for what I want for transparency is I want something more like the supermarket. I can go in and find out what the prices are before I actually have to purchase something, and I can see the different prices arrayed against each other and all of that. We are so far from where we should be on transparency, and I think we're going to hit a point. I mean, this is my. I can get a little preachy at times, but you know, my preaching to the hospital choir in particular is whatever sort of burn your side now transparency is, it's only going to get worse, and it's going to keep getting there until you can, you know, just think about whatever you least want people to know about how you price things or structure everything. Think that that's going to have to be in the public domain pretty quickly, and faster probably than you think, and then figure out how to do your business under that realm, because the idea that, you know, the way in which we're going to go on these issues is, gee, since the first iteration out of the box wasn't enough and we could kind of poke holes in it, people are going to say enough is enough and let's put the genie back in the bottle. It's going to go the opposite way, which is, well, if that wasn't enough, then give me more so we make it better, and don't tell me that we're going to go backwards. So I don't think any of this goes backwards. We did do a thing in Oregon that we've gone backwards on in that state since I did it, which was the insurance companies came to me and said, you know, that we're working with all the private employers, and they wanted we were going to give them all of our hospital pricing data. This was the guy that ran the Blue Cross plan there believed deeply in consumerism, and so he was willing to say, I'll be part of this whole deal. To sort of, we'll all share our prices through a private employer coalition, and then they'll produce reports that Milliman will do, showing what the different rates are for different DRGs in all the hospitals. And the hospital said, there are clauses in your contracts that prohibit you from sharing this data. You can't do it. So literally the insurers came to me and said, we really, really want to do this, and we've decided that if you ask us for the data in a market conduct exam, we will have to give it to you, and those hospital contracts won't preempt that. That, doing business the way we do in Oregon, which I wish is the way we did business everywhere, I immediately called up Andy Davidson, who's head of the hospital association, and said, I think these guys have a good argument. We're going to do this. What do you think? And he said, well, let's talk about it. And it took a year of talking back and forth, and we finally structured something to do that. And then it wasn't enough disclosure, and so it didn't work very well. But I asked Andy lately, and he said, well, no, that's the start of it. Yes, it's not going away. We're going to do more, and we've done a lot more since then. So I think you can look at all these examples and say, well, all that transparency is a little weaker than it should be, and it hasn't really done as much. The same thing on quality. I mean, all the quality experts told me, the quality is primitive. People don't buy on quality yet. But the answer that's going to be to continue to improve it until people do pay attention to it, until people do shop. And that's where the big bet here is cost sharing. If cost sharing stays part of this law the way it is, it's actually a very Republican idea. And I think we can't afford, we're not going to be able to afford. I mean, people say, well, I hate these bronze and silver plans because there's just too much cost sharing, particularly for people at low income levels. And I'm like, well, okay, so let's look at Congress. Are they debating eliminating bronze and silver, or no? I think they're debating adding whatever it is, that it's a 50%. What's it called? So they're calling it something else. What is it? Say it again. Dirt. That's not the phrase they use. But it's a 50% cost share. Whatever metal they use here, it's a 50%. They're debating adding a 50% cost sharing, not going the other way. And if you're going to have that kind of cost sharing, you are going to have consumers saying, you know what, actually, I do need to know the price before I decide which place I'm going to go and so forth. So I think it all goes that way. So that's a bit too argumentative, but, you know.
Thank you. I think we're going to move on to
Okay.
the next presentation. But round of